So thank you very much for the introduction, and also I would like to thank the organizers for inviting me here. So it has really been a pleasure being here. I really like this meeting. It's exactly the right size. You meet people again and again, and you have great conversations. So it's really been great. So thank you very much. And now I will talk a little bit about what we do at ETH Zurich, especially in my group, in my research group. And as was announced, I'll try to bring the models we develop into clinical practice. We are not quite there yet, but I will tell you what we do and where we are and what the challenges are. So the overall aim of my research group is to improve patient care with machine learning. This is what we aim for. And we are a computer science lab. So we are in this corner here. So we are the machine learning researchers. We have a background in computer science and mathematics, maybe in physics. We do not work with patients. We are not generating data. And this means if we develop models by ourselves, it might be likely, so we will develop great models, of course, that are efficient, that do great stuff, but it might be that we develop models that are actually not usable in practice. And to achieve our aim of developing models that actually help patients, we need our clinical collaborators that are on this other side of the island here. And they have the data, they develop, they work with the patients, they know exactly what the clinical needs are. And I work at this intersection, so it's important to me to bridge this gap and to find projects that have a clinical impact and also methodological contribution. So we develop machine learning models mainly in the areas of multimodal learning, unsupervised learning, generative models, also interpretable, explainable AI. That have a methods contribution, and this is what we publish in the machine learning venues, and then we implement this for the clinical like use case and publish this in the biomedical domain. So we walk this often narrow path of what is methodologically interesting and also has a clinical impact. And for this, the clinical collaborators are very important. And as I said, I try to find projects that are interesting to us from a methods point of view. So the application area differs a lot. So I try to find projects where the data is interesting, the problem is interesting, but we do not have like one specific type of application. The application varies. And here you see a few examples of projects we are working on. One is, for example, in rehabilitation. Here we help detecting gait patterns in patients suffering from stroke. So we have these sensors that are all over the patient, and we monitor how the gait pattern changes given some incentives, and this is what we do in this project. We have a project on sepsis in neonatals. We have a project in appendicitis, in detecting heart defects, on phenotype extraction, on neurological disorders like general movement assessment in newborns, also on rare diseases and on type 1 diabetes. So these two projects actually have been presented here. So they were in the last few poster sessions presented by my students. And I will focus on these two projects in this talk. So to give you two specific examples, what we did in these cases and where we stand. So I will start with the project on detecting heart defects in newborns. So the idea here is to detect congenital heart defects. So congenital heart defects are heart defects that are present at birth, and they affect the structure of a baby's heart and the way it works. So they can be structural or functional. Structural meaning there might be some holes in the heart, or functional, it might affect the structure of how the heart pumps the blood. And those are usually diagnosed with echocardiography, so with ultrasound. And early screening here is really crucial to ensure long-term health of these babies. So if these heart defects are missed and only found out later, the baby or the child might already suffer from consequences. So the earlier detected, the earlier it can be treated, and this is what we aim for here. And here we see 3 examples of these congenital heart defects. So this is how a normal heart looks like, and this is this defect called CAVC, where these heart walls are all not connected. Then another congenital heart defect is this VSD, where it's a small hole in this lower heart wall here, or the Epstein anomaly, where this heart wall here is not closed. So these are a few examples. There are more. And we work on this on ultrasound data. So what we get is we get these ultrasound videos from newborn babies. And these ultrasound videos are quite cheap to acquire, but they're very noisy to interpret. And this is already the case for adults, and it's even more challenging for newborn babies. So here's a photo of our collaborator in the University Hospital in Regensburg, where he performs such an ultrasound on a newborn baby. It is a preterm baby, so you see they're really tiny, and also the hearts are tiny. And in addition that it's really challenging to see these heart defects quickly, even if parents are around, they might ask questions, they might be nervous, so it's really a stressful procedure, and it can take quite some long time, but you don't want to stress the baby too long, so it should be fast. And in addition to this, it's also that the heart of the baby changes a lot in the first weeks and months. So what is normal directly after birth might already be abnormal a few weeks later, so also you need to take this into account. And this is where the project started. So they contacted us, they said we have these heart ultrasound videos in different angles. We get them in 5 different angles. So depending on where you place the ultrasound head, you get a different angle of the heart, and depending on the angle you might see the anomaly, so this defect. You might not necessarily see these holes in the wall in every of these views, but in some of these views. And this is why we want to have all these views and take all this information into account, because in some of these views actually this defect might not be visible, but in another it might be visible. And this is what our starting point was, to start with these ultrasound videos. So now these congenital heart defects occur quite rarely, so they're not too frequent. But what is done frequently is these echoes of the newborn hearts, and this is during standard screening directly after birth. So we have many of these videos actually from healthy babies, but not too many from babies having this heart defect. And this is why we approached this using an anomaly detection approach, where we developed a model that builds a model given this healthy hearts, these healthy videos we have. So we build a normative prior of the healthy heart, and then at test time we can see if the heart we look at is actually healthy or diseased. So this was the idea behind it. And an observation we have is that the heart beats periodically, so we have this periodic heartbeat. The videos are approximately periodic, and this is what we would like to use, this is what we like to leverage. So the idea was that we use here a variational autoencoder that mimics this periodicity, and we model prior and posterior S distributions over these periodic functions. So this is the idea. We have, we reconstruct how a healthy heart would look like, then we subtract this reconstruction from the video we look at, and then we finally get a visualization of the differences of the heart we look at, how it differs from a healthy heart, and then we also can pin down where actually the differences are. So we see here in this image where the model thinks the heart differs from a healthy heart, and this is something that is useful for the clinicians, that they can actually zoom into these regions where the model thinks that these hearts deviate. And this is the structure of the model. So it's a VAE-based approach. So we have an encoder, decoder model. We have here some prototypical function, where we also learn the heartbeat, and we get some parameters that describe some specific features of the heart. And for this function, we have 3 different versions. One circular version that takes the periodicity into account, and then a rotated version that also distributes the time component over all dimensions, and also the spiral version where we also take care for spatial dependencies and spatial shifts, which is especially important because we might have zooms in and zooms out in these videos, and this is what this spiral model then can capture. And this is how an example of videos, how the final model looks like. So on top here you see the original input videos in different views, and here you see the 3 different versions of our model. And here are healthy hearts, so these are examples of healthy hearts, and then you see that this is all these shades of blue. And for anomalous hearts, you see that here it detects these anomalies, and it shows us where these anomalies are. And this is what we call it has an explainable component, because we not only tell our collaborators this heart is probably healthy with a specific maybe variance, but it also, we can show them where our model thinks the heart deviates, and so they can look actually at the specific region and see if they find something there or not. And this was work done by these students. we have been working on this over multiple years, so it started. Actually, the first paper was actually published at this conference in 2002, and then we had some different types of work looking into specific congenital heart defects, and also ejection fraction and Epstein anomaly and these types of things where we had some follow-up work on this. And now I was talking about this explainability component. So I've learned, or I've realized in my last years working with clinical partners that for some of them, it is actually helpful if we can explain what is happening and that it's not a complete black box. And also my experience was in my very first years as an assistant professor, we had a predictive model, it worked very well, it was a black box, and we wanted to actually build a company out of this and build a startup and bring this into the market. And in the very early steps, we realized that as this is a black box, this European German General Data Protection Regulation has a right for explanation, which was not fulfilled. So they decided very quickly that the machine learning part is out. And I found this quite sad. So then I thought, okay, we probably at least sometimes need some models that are explainable or interpretable. Sometimes because it helps gaining trust in clinical collaborators or helping us to convince the founders that this actually all these checkboxes that are needed to go through a certification process are checked. And this is why I also started to look into this more closely, and this is just a terminology. So I differentiate between interpretable and explainable models, and this is not a definition that I made, it's just a convention, so there is no clear definition what these terms mean, but this is what I mean when I talk about it. So with interpretable, I mean white box models, where we understand how a model works, and here are some examples of what is usually considered to be interpretable models. And for explainable models, I mean more black box models, where we explain post-hoc what is happening. And this is what the example you just saw, where we have some visualization and we see what is, so the model itself might be a black box, but we explain later on what is happening. And in the next few minutes, I will focus on this interpretable high-level concepts, where we use human understandable features, human understandable concepts to insert some interpretability layer into the model, and also a layer that makes it feasible for a user to interact with the model. And this we built in the context of pediatric appendicitis. So this is a project where we were approached because it still seems to be difficult to correctly diagnose appendicitis, and also the management and its severity. And when I was approached with this, I was surprised because I thought appendicitis is so common. But obviously it's still very difficult to actually diagnose correctly. And at least in Europe or in Germany, it is the case if it's diagnosed, if you're in appendicitis, you can decide if you treat it surgically, so if you remove the appendix, or if you treat it conservatively, give some medication. And our collaborator said that the surgery is performed far too often. So in this project, they want us not only to correctly predict the diagnosis, but also to tell them, is the surgery actually necessary or not? And how likely is it that there will be complications? And if it's the probability for complications are high, then it's more we should take this operation. So the aim is here to reduce unnecessary surgeries. This was one of the aims in this project. And we started first with tabular data. So the data here is collected if a child, so this is an adolescent, like very early child to 18 years, and if they come to hospital, data is collected, like there is usually an ultrasound examination done, where one has some ultrasound findings, some physical exams if the patient has a fever, and some lab tests are done. And we first started with this tabular data, where we used the tabular data and some classical machine learning models to diagnose this, and this worked very well, so everyone was very happy. But we thought, okay, this is only actually on the tabular data, and we did not make use of the raw ultrasound images. But it would actually be quite nice if we can just take the ultrasound images and based on these images, predict our outcome. And this is what we did in the next step. We tried to make use of these ultrasound images directly. And for this, we proposed a model that is based on concept bottleneck models. And the concept bottleneck model works in a way that first human understandable concepts are predicted and then the target variable. So this means here we have an image as an input, And then instead of going the prediction directly from the image to the target, which in this case would be the diagnosis of appendicitis, we first predict human understandable concepts, and then we go from the concepts to the target. So this is the workflow in a concept bottleneck model. And then one can intervene on these concepts, and this is what makes this very nice, because it adds a layer where one actually can interact with the model and see how the outcome of the model changes if I change these layers inside here. So the limitations of the vanilla version of these concept bottleneck models was that they can only deal with single inputs. So as a first step, we extended this model to be able to deal with multiple inputs because we have multiple ultrasound images. So this was the very first extension to be able to deal with multiple inputs. And then for this, we need concepts, right? So it's a concept bottleneck model. We need to predefine concepts. And these are 9 concepts that were defined together with our clinical collaborators in this project. And these are, for example, if the appendix is visible, if there is fluid, how the appendix layer structure looks like, if there's a surrounding tissue reaction, and so on. So we defined 9 of these concepts, and this is what we used. So this means if we have this ultrasound image, we first predict these 9 concepts that are predefined, and then given these concepts, we finally predict our diagnosis. So this is what happens here. And this is why it's called a bottleneck, because it's really the final prediction is only based on these concepts. And then we can also intervene on these concepts and change these values. And what I mean by intervention, so it's not an intervention in a causal sense, it's really just changing these features. And this is a made-up example. If we have this ultrasound image, and then we have our predicted concepts. So here it might be that the appendix visible is a very low probability, free fluid as well, and then the prediction algorithm says no appendicitis. But if our collaborator looks at this and says, actually, I see very clearly that here there is some free fluid and also the appendix actually is clearly visible, one can manually adjust these concepts, change the value, and then by changing the value, we get a different prediction. And this is what intervention means. So there's no causality involved, it's really just changing values, and with changing these values, we get a different prediction in the end. And now I showed you this concept set we have. So we have these 9 concepts, and this concept set is actually often incomplete. So this is a very small concept set, right? If you look at the whole image, you make a prediction, and then you go from this whole image to this very small set, it might actually see that there is, what happens is a so-called performance interpretability trade-off. So you add this interpretable layer, you have these concepts that a user knows what it means. However, the performance might drop because you restrict yourself to a very small set. And this is not what we want. So our question was, can we actually resolve this trade-off? Can we have an interpretable model? Can we have these human understandable concepts, but not suffer from this performance drop? And for this, we developed a new model, which we call semi-supervised multi-view concept bottleneck model, where in addition to this concept bottleneck arm, we add an unsupervised encoder, where we learn features in an unsupervised way, and we add regularization step, where we make sure that these predicted concepts and the learned representations are independent conditioned on the label, because we do not want to learn some redundant concepts. We do not want to learn something similar again. We want to learn something in addition. And then finally, given these concepts and the learned representations, we predict our target. So this is then our final model. And as a reminder, we need these 3 tuples. So we need the input data X, we need the labeled concept C, and we need our target Y. So this is the input we need. And then what happens first is, we extract view-specific features from every view. Then we fuse these features across the views, and then we do some concept representation prediction. So the concepts are predicted and the features are learned. And finally, these are concatenated. And with this final concatenation, we then learn our target value, in this case, diagnosing appendicitis. And then we can, at test time, still intervene on these concepts. So this we did not lose. And with this, we can handle multiple and varying number images per subject. So we can handle these multiple ultrasound images we have. And we can also handle incomplete observed concept sets, because these concepts might be too small. It might be because it's costly to annotate them. It might be that there's just no knowledge that there is something important. And with this semi-supervised arm, we avoid this. And here you see some results. So this is how a random model would perform. Radiomics plus RF means we extract features from the imaging and just train a random forest, where performance is not so good. But then here you see the single view black box model and the single view concept-based model, and here this performance interpretability drop happens. You see that the black box on just one image performs better than the black box if we restrict it to this concept set. And the same for the multi-view model. So the multi-view black box performs better than the multi-view concept-based. And we do not see this drop with our semi-supervised model. And here as a reminder, so our aim is not to beat state-of-the-art models. Our aim is to be on par, but having this interpretability component. And this is why we were quite happy here that we achieved this. So we have now our interpretable concept sets, and we are not worse in performance than the black box models. And now the question is, so what happens now? So do we stop here? So we now have our model, we have our research paper, and if we stop here, what happens? So ideally, I would like that this is implemented and helps actually in the clinic. And here I would like to cite Duncan Watts, who put in words what I was thinking. And he said, for 20 years, I thought my job was, as a basic scientist, to publish papers and then to throw them over the wall for someone else to apply, right? This is what we often do. So we write a paper, we think this is great, and now someone, please apply it to your domain. But especially if you're working in these interdisciplinary fields, it's quite unlikely, or at least in many hospitals, it's unlikely that the clinicians will go to our GitHub, download the code, and use it for the data. So this is why he also realized that there is actually no one on the other side of the wall, just a huge pile of papers that we've all thrown over. So this is not what we want. We want that this is actually used and helpful. And the first step that I think might be important is this transparency step, and this is what we have. But what we still need is we need some tool. We need something that is actually usable in daily clinical life. And this is what we did as the next step. So we developed this pediatric appendicitis prediction tool. This is freely available. And this is the screenshot of the landing page. And this is what all these red banners I had to add for ETH. Because ETH Zurich has no liability, it's a prototype, so I had to really make sure no one can sue us, and it's like not be used for medical purposes, it's for research purposes only, and so on. So it took us some time until we were there that they were happy with us putting this online. And this is where we are now. So we have two versions of this tool, one for the tabular data and one for the imaging data. And here you see the tool for the tabular data, so this means really the clinician types in these values, and this is a real case. This was a 3-year-old child that came to the hospital, and then the height was noted down, how heavy the child was, the body temperature. And what one needs to know is for children in this age, at least this is what I was told, is that appendicitis is not so common. Intestinal infections are a lot more common. And children in this age are often unable to really communicate that the pain is different than what they usually have if the stomach hurts and so on. So just given, so the clinician looking at the child decided not to perform surgery. But then they put these numbers into the tool, and actually the probability that the patient has appendicitis was quite high, and also the probability that the kid needs surgery was quite high. And in the end, the clinician decided to perform surgery on this kid, and it turned out that this was really necessary because there was already some surrounding abscess beginning, which can lead to complications. And so this is just one example, right? It's one anecdote, but I know this anecdote because the clinician sent it to me and said he was very happy, and it changed the surgeon's mind, what is apparently not that common. And now we try to monitor this more systematically to see actually what does our tool predict, how do people use it. But so far it's really just out there and it's not monitored in any way, and now we want to change this and see what are the cases where it helps in what way. And then this is the tool for imaging data, because I thought you really need to type in many values, right? And this is kind of annoying. So what if we can just upload the images? And this is what the idea of this imaging tool was. that we can just upload these images, and here you see how it works. So the clinician uploads the images, then these images are pre-processed, and then as a first step, the 9 concepts are predicted. And here you see these concept predictions with the histogram of the prediction of the training data in red for appendicitis and in blue for not having appendicitis. And as a second step, then the target variable is predicted. So here the risk for having an appendicitis. And as the last step, one can intervene on these concepts. So here you see these yellow boxes is where an intervention happened. So the red arrow is the value before the intervention and the black after the intervention. So we change these values, and by changing these values, you also change the probability for the outcome. And so the manuscript, the dataset, and the tool are publicly available. And I would like to emphasize that I'm especially happy that we could publish the dataset. This is actually nothing we can usually do. So here we were very happy that our collaborators agreed, and also ETH agreed. This was also a long process, but here we can really publish all of it. And yeah, these are my students who worked on this. It's also like, has been a long process. And it's now in the process that we finished this on one hospital, and now we are in the process of collecting data from different hospitals to see how does our model actually translate to other hospitals, to other settings, to other ultrasound machines, and so on. And yes, so these are about 2 projects I wanted to present to you today, where we developed the models and we try to bring it into clinical practice, and it's at least something that's out there. It's not, not certified. Not a real medical device, but at least it's something we can give our collaborators at hand, and they can use it whenever they want. So, and this is only possible with my national and international collaborators. As I said, ETH, we do not have a hospital, so I really rely on one-on-one collaborations. And these are my collaborators I work with, and I would especially thank my research group that works with me on all these projects. And now thank you for your attention. Thank you very much.